everyone, and welcome to MindMatters Masterclass. Tonight's theme is on fears, facing your fears, dealing with anxiety disorders, chronic worry, panic attacks, and all kinds of irrational fears. Now, fear, of course, is a very good human barometer to help you, guide you in life. But when it becomes chronic, it becomes a disorder, then it becomes very debilitating, right? And who better to present to us this topic of facing our fears than Associate Professor Dr. Leslie Lim. He's a senior consultant psychiatrist, a clinical associate professor at NUS. He is a very decorated psychiatrist in Singapore, having won the Distinguished Psychiatry Award, as well as a former council member, College of Psychiatrists, Academy of Medicine. At this point in time, if you could help me, welcome Dr. Leslie Lim. Over to you, Dr. Lim.
Thank you very much, Glenn, and welcome to tonight's talk that I'm going to go through very fast because I've got a lot of slides, a lot of material to share with you. So without further delay, let's launch into the talk. Facing your fears. Now, the definition of fears is that they are a vague sense of apprehension and restlessness, often accompanied by symptoms, physical symptoms. So there are psychological symptoms of apprehension, fear, worry, and there are also physical symptoms. Now, just a bit of the differentiation between fears and anxiety. Fears are a response to an external threat, a known stressor, whereas anxiety is a response to no particular threat or stressor. So this is just a minor point to differentiate between fears and anxiety. So for tonight's talk, we shall use the terms synonymously, fears and anxiety synonymously. So what are normal fears? Normal fears arise even from the time of birth. If you make a loud sound, the baby is going to be startled, and they will have what is known as the Moro reflex when they have opening up of their arms and then embracing. The kind of movement is present at birth. It disappears when the child is older, but it goes to show that children, even newborn babies, can react to loud noises. And then from the age of 6 to 7 months, they start to become fearful of strangers. And then from age of 2 to 4, fearful of animals. And then subsequently, there's fear of heights, fear of being stared at, and you must be fearful of exams or else you will be studying and revising. Public speaking is one of the greatest fears that afflict humankind. And parachuting, if you are fearful of parachuting, that's quite normal. But if you are not fearful of parachuting, then you can be a commando, you can be a parachutist, and you can sign on and serve in the special forces. So fear plays a protective function because it protects us from accidents and acting recklessly. When do fears become abnormal? They become abnormal when it is out of proportion to the stimulus, when it interferes with your daily life, and it leads to avoidant behavior, or it is more severe than when compared to others. For example, you are afraid of cockroaches, right? Most people that don't like cockroaches are afraid of cockroaches, but you have an insect phobia when you think that a room has got cockroaches, you won't even enter the room. But for the rest of us, although we don't like cockroaches, we can still enter the room, we can still sit on the chair and the couch, we don't avoid the room. Now, there are two researchers by the name of Yerkes and Dodson. They are psychologists who found that when anxiety is has a co-relationship with performance efficiency, such that when anxiety level is very low, performance efficiency is also very low, and person may even be asleep. But when anxiety level increases, performance also increases up to an optimal level, beyond which, with further increases in anxiety, performance decreases. Up to a certain stage, then they reach a stage where they develop symptoms of anxiety, and then they can't cope. So some anxiety is good for performance because it makes you more alert, helps you to think faster, helps you to react faster. Now we're talking about anxiety disorders tonight, and there are basically 3 types of anxiety disorders: generalized anxiety disorder, panic disorder, and phobic disorder. So some information about the social demographic characteristics of these anxiety disorders. In the US, where there are a lot of studies and extensive research done on anxiety, it is found that anxiety disorders are more prevalent than alcoholism and mood disorders. These two, alcoholism and mood disorders, are the most prevalent disorders in the USA. Worldwide, it is found that anxiety disorders are twice as common in females compared to males. And they cause a lot of burden for patients and their families. By burden, it means quality of life is impaired. It means a person does not feel a sense of well-being and they are not able to perform as they should. And also, there is also increased use of medical and psychiatric services because they have physical symptoms. They may go for a checkup. They may go and see a doctor because they have certain physical symptoms. As I mentioned, there is reduced work productivity and quality of life. And also, not to forget that anxiety increases the risk of suicide by 10 times that of the general population. Very often we think that depression causes suicide, but anxiety as well can lead to suicide. Locally in Singapore, there have been studies over the years, and the 1 year prevalence is 1.5%. That means in the space of 1 year, 1.5% of the population have got a generalized anxiety disorder. This is an old study published in 1998. More recently, a study that I published 20 years ago found a lifetime prevalence of 3.3%. In other words, 3.3% of the population of Singapore were at risk of suffering from generalized anxiety disorder. More recently, the prevalence rate is 1.5%. As I mentioned, females outnumber males, and the ratio is 2:1. And GAD, or generalized anxiety disorder, is 4 times more common than panic disorder, 3 times more common than simple phobias. The age of onset is difficult to gauge because most people say they are anxious all their lives for as long as they can remember. So they can't really tell us when anxiety really started. So my take on this, my speculation is that very often generalized anxiety disorder develops as a result of a person's pre-morbid personality. In other words, they were having an anxious personality to start with, and so this anxiety disorder called GAD develops imperceptibly, seamlessly from their usual personality, which is anxious to start with. That's why they say they're anxious all their life. They can't tell us when the GAD symptoms first started. Now, how do we diagnose GAD? Very, very simple. I've divided the symptoms into 3 major categories. Firstly, psychological symptoms. We saw that earlier on that people with GAD feel fearful. They complain of being irritable, angry easily. They're excessively worried, and sometimes because they're thinking a lot, even if they have nothing to worry about, they tell you their minds are very active at night. They're thinking of random thoughts. They have poor concentration at work. Even when they are at home, they have poor concentration. They have sensitivity to noise. They're easily startled by loud noises. I even had a patient who fell off a chair when her name was called by her mom. She fell off a chair because she had this startled reaction. Secondly, there are physical symptoms, and physical symptoms arise from the cardiovascular system, fast heartbeat, chest discomfort, and so on. And gastrointestinal symptoms can also arise, such as dry mouth, difficulty swallowing, discomfort in the tummy, wind, diarrhea, urinary symptoms, frequency of urination, and sexual symptoms, which are less often complained of because people are embarrassed to talk about it, impotence and missed periods, and so on. And there are neuromuscular symptoms, pins and needle sensation, ringing sound in the ear, and so on and so forth. There's also a sense of restlessness, can't relax. So a person has a difficult time at work and they're stressed up at work. Even when they go home, even when they are away from the source of the stress, they can not relax themselves. And so it's likely that they have what is called GAD, generalized anxiety disorder. And the third main category are sleep difficulties, characterized by difficulty initiating sleep, difficulty falling asleep. So a person lies in bed, they toss and turn, they fall asleep after 1, 2, 3 hours, and sometimes they cannot even sleep the whole night. GAD is very often associated with medical conditions. So chronic heart conditions, lung conditions, orthopedic conditions like arthritis, gastrointestinal problems, migraine. So if you're anxious, it can lead to you suffering from a whole host of medical problems. Of course, medical problems can also lead you to feeling anxious. So there's a two-way kind of relationship. Now, these are not causal, not necessarily causal. They are more like an association. Of course, there may be a possibility that GI problems, gastrointestinal problems, may lead to secondary anxiety, and vice versa. Anxiety can lead to generalized and gastrointestinal problems. So as I mentioned, that the age of onset is very hard to estimate, and so researchers have found that the onset could be as early as 14.6 years. up to 20 years as the mean onset, the average age of onset. Notice it happens, it arises in a young age group. Worldwide, the studies have shown that this condition is associated with people in the lower socioeconomic rung of society, the poorer people. The study that I conducted and I published 20 years ago showed that in Singapore, the richest in this country also have a proneness for developing GAD. And we will see later on that life events, stressful environmental stresses can precipitate the onset of this condition. And my study has found that people who are in the richest socioeconomic group have a different set of life events compared to those in the lower socioeconomic group. Well, what is also known is that those who are divorced, the previously married, those who are not working, those who are homemakers, that doesn't mean that if you are a homemaker, you're more at risk of developing this condition. Doesn't mean that. But it may also suggest that if you are not well enough to go to work, you just stay at home and be a homemaker, which is also a full-time job. Same thing, the unemployed is because they have got symptoms and they're not well enough to work. Or the retirees. There are also secondary psychiatric conditions to the primary condition of GAD, such as depression, specific phobia, panic disorder, alcohol dependence. Alcohol dependence because people take to drink to suppress the anxiety symptoms. So you can see that GAD is very often not able to exist on its own. It's very often associated with some secondary conditions. So in only 10 to 26% of GAD, there are no secondary conditions. In 10 to 26%, they exist on their own as pure GAD. The reason for this is that the longer the delay in seeking help, the more likely to develop a secondary condition. So what are the causes of GAD? Same with the causes of any psychiatric condition. Two major groups of causation. Firstly, genetic factors, and secondly, life events or environmental stress. Genetic factors, we can find that there are relatives, first-degree relatives with the same condition. First-degree relatives refers to a person's child or sibling or parents. These are first-degree relatives. 25% of first-degree relatives have got GAD. So this is a good evidence that this condition is genetically inherited. Secondly, life events such as divorce, such as financial problems, problems with the law, of sick relatives, and so on. Then there are biological factors, abnormalities of chemical balance in the brain. And these chemicals are called neurotransmitters. These chemicals are responsible for carrying impulses, carrying messages from one nerve cell to another. And these neurotransmitters are serotonin, noradrenaline, glutamate, and so on. Okay. Some have even found that there is a lower metabolic rate in certain parts of the brain, such as the basal ganglia, which is also connected with a person's, responsible for a person's emotional reaction. There are psychological theories, such as cognitive behavioral theory. For example, a person may overestimate the dangerousness of the situation, such as public speaking. You overestimate the threat and underestimate your ability to handle that situation. Then there are psychodynamic theories, and this is from Sigmund Freud, the father of psychiatry, and he claimed that there are unconscious impulses, and according to Freud, the two types of impulses are sexual impulses and aggressive impulses. So his postulation is that these unacceptable impulses are being repressed because they are unacceptable to express them openly, so you repress them. And the more you repress them, it's like a kettle of boiling water. You stop the spout, and the pressure builds up within you and within the kettle, and then it explodes. So it comes out in the form of anxiety symptoms. Now, what happens when a person is under stress? Now, stress affects the brain. Let me just give you a bigger picture. Okay, so you can see here, stress is being perceived by the hypothalamus, which stimulates, which releases CRH. This is a hormone, which acts on the pituitary gland, and pituitary gland secretes ACTH, a hormone, which then informs the adrenal. The adrenal glands sit on top of the kidneys, and there are two portions of adrenal gland. The peripheral portion secretes cortisol. And the internal portion, the inner portion, secretes adrenaline and noradrenaline. Cortisol increases a person's blood pressure and stimulates glucose release from storage in the liver. At the same time, it suppresses immune response. Cortisol is a steroid. It's a naturally occurring steroid which suppresses inflammation. As I mentioned, adrenaline and noradrenaline are secreted by the adrenal glands, and these affect the sympathetic nervous system. And when the sympathetic nervous system is being stimulated, it prepares the body for fight or flight. So you meet with a certain danger, there's a fight or flight response. But the problem with anxiety disorder is that it is a false alarm. There is really no big danger, and yet the body is geared as if to fight or to take flight from that source of danger. And this gives rise to the E activities such as exercise, excitement, emergency. These fight or flight response is to help to deal with all these situations of exercise, excitement, and emergency. So what happens in these E activities? There's increase of blood flow to the muscles, increase of heart rate, breathing rate and depth is increased. So the heart beats faster and pumps oxygenated blood to different parts of the body, especially to the muscles, to enable the persons to fight or to run away from the danger. At the same time, the skin is cold and sweaty because you don't need much blood flow to the skin. And some researchers postulate that when you are meeting with danger and your skin doesn't have much blood flow, it is good because you do not lose much blood when you are injured. Now, pupils dilate, bronchioles are part of the tubes that lead to the lungs. It's the airways that lead to the lungs dilate so that more oxygen can be absorbed from the air into the bloodstream. So there is constriction of blood vessels to the skin and the gut, and the liver releases more glucose into the blood by way of noradrenaline and adrenaline. These are actually chemical reactions that break down the storage, the energy stores from glycogen into glucose to supply energy for fight or flight. The non-essential organs slow down, the GI tract, the urinary tract. There's less blood flow to the non-vital organs such as the skin. Now let's quickly move on to panic disorder. Panic disorder, this is a condition which is not well understood even by doctors, even by qualified doctors, because they fail to diagnose it. Why? Because they do not ask the right questions. So they fail to recognize and to diagnose and to treat this condition. Panic disorder is characterized by a sudden onset of acute anxiety which arises out of the blue. There may not be any stressor. You might be in your sitting room, you may be watching a movie or reading a book, and suddenly you develop a panic attack. And there are at least 4 out of 13 symptoms, 4 or even more. But on the whole, there are 13 symptoms, and the attack lasts for minutes and subsides at most 30 minutes. If there is fear of the next attack and this fear lasts at least 1 month, you can confidently diagnose panic disorder. Panic disorder is diagnosed when there is panic attack with at least 1 month of fear of recurrence of the attack. What if there are fewer than 4 symptoms? Fewer than 4 symptoms, you would call it a limited symptom attack. It's a milder form of panic attack. Now, people who have panic symptoms make visits to the A&E departments because they fear they're going to die, and they request for examination and investigations, and it's a result of catastrophic thoughts such as dying, fear of dying. We will see later on what are these symptoms that make them so fearful. So let's look at the characteristics. 1-year prevalence is 2% in Singaporeans. The lifetime prevalence in the US is between 1.5 to 3.8%. Average age of onset is 25 years. Notice that it is a bit later than GAD. The female-male ratio is 3:1, whereas GAD female-male ratio is 2:1. Again, those who are separated or divorced are more at risk. And for children and adolescents also have this condition, but it may not be diagnosed, and so it seems to be underreported. So what are the symptoms of a panic attack? You have palpitations, breathlessness, choking sensation, chest pain, nausea, abdominal distress, feeling dizzy, lightheaded, and there are feelings of unreality called derealization or depersonalization. Derealization is very hard to describe. It's a feeling as if you feel unreal in relation to the world. That's depersonalization. For derealization, you feel that the world is unreal around you, and usually it is quite a normal phenomenon. If you're very tired, you have a jet lag, you may have a feeling of derealization, but this is This is seen in people with a panic attack. Pins and needles sensation, fear of dying, losing control, or going crazy. I call them the catastrophic thoughts. There's trembling, shaking, sweating, chills or heat sensation. Now this appears to be completely opposite to one another. You feel chill in your extremities, your hands and legs feel cold, and your inner core feels warm. So you have a mixture of heat and cold sensation. And because your body temperature is rising, you have sweating to cool yourself down. There's also the phenomenon of nocturnal panic when a person goes to bed and they wake up in the middle of the night, between 1 to 4 hours after sleep, onset of sleep, and you wake up with an attack. When you're sleeping, there's nothing that triggers off the attack, right? So this is something that goes on in the brain. Okay, the panic center in the brain is being stimulated, not by external stimuli, external stressors, because you're sleeping, but internally, some biochemical changes are taking place. So the comorbidities of panic disorder are phobias, and there are actually 3 types of phobias, but agoraphobia and social phobia are associated with panic disorder. There's also illness anxiety disorder or hypochondriasis, when a person thinks that he's suffering from some medical condition. And because they have all these symptoms and they are not able to go to work because they're fearful of leaving home and they lose their jobs, they have no income, therefore they feel depressed, demoralized, and they may develop suicidal thinking and suicidal actions. Or like in the case of GAD, they will take to the bottle and drink to suppress their anxiety. So what is the cause and prognosis of this condition? Like all anxiety condition, it tends to be chronic. It can last for many years. 30 to 40% are symptom-free at follow-up. 50% of them have mild symptoms. And 10 to 20%, fortunately, only 10 to 20% of significant symptoms at follow-up. So caffeine, drinking a lot of tea and coffee can trigger off the attacks. Nicotine from your cigarettes can also exacerbate the attacks. So biological symptoms, biological causes involve the abnormality of noradrenaline, serotonin, and GABA systems. These are all neurotransmitters, and there's always a fine balance. If there's imbalance of these chemicals in the brain, then panic attack, anxiety may develop. I mentioned the panic center in the brain called the locus coeruleus. This is a collection of nerves in the brain stem, and they are sending wrong signals to inform the body that the body is under some kind of attack or threat, and so it sets up a panic attack to deal with these the threat, the perceived threat. Of carbon dioxide hypersensitivity. That means in the laboratory situation, if you get the person to inhale a lot of carbon dioxide, it can also trigger off a panic attack. That's why it was thought that a person should breathe in and out into a plastic bag or a paper bag when they have a panic, and that is not the right treatment, because that's going to increase the level of carbon dioxide in the blood and going to trigger off another attack. So while it has been taught that you should breathe in and out, that is not the right technique. Disturbance of lactate metabolism. For example, if you do a lot of strenuous exercise, your lactic acid accumulates in the muscles, and this may trigger off a panic attack as well. Other causes are genetics. It's found that in family and twin studies, the risk of panic disorder is 10 times higher than for those who do not have a history of panic. So for family members and for twin studies, it is shown that you have identical twins, they are more likely to suffer from this condition in the co-twin compared to non-identical twins. Now, learning theory, this is a theory put forward by psychologists. It's when a neutral stimulus is paired with a noxious stimulus. So for example, a neutral stimulus is the MRT station or a train, neutral stimulus. So for example, on a day when you're rushing to work or you're rushing for an interview and you're late, and you go into a train, unfortunately the train stops inside a train station and decides to take a rest in a tunnel, and you're very fearful because you're late for your interview or you're late for your work and your boss is going to meet with you and he's going to scold you. So you tend to identify, you tend to associate train station as being a dangerous place because a train is invariably going to stop in a tunnel, so you avoid. You avoid train stations altogether. We mentioned the locus coeruleus, which is a panic center of the brain. It's somewhere here. This whole area is called the brain stem. So you can see that the locus coeruleus is connected to the rest of the brain by all these connections. So a close relative of panic is phobia. And earlier on, I alluded to fear of the train station when the train stops in a tunnel. And so panic is often associated with phobias. Develop a panic attack in the train, you will develop an avoidant behavior to travel by train, and so you develop a phobia of traveling by train. So phobias can be defined as fear of an object or situation. It is out of proportion to the stimulus. It cannot be reasoned away and leads to avoidant behavior. And there are three main groups of phobias, namely agoraphobia, social phobia, and specific phobia. Agoraphobia comes from the two words, agora, which means market, phobia, which means fear. When put together, it refers to fear of the marketplace. But nowadays, we know that agoraphobia sufferers are fearful of more than just going to the market or supermarket. They have other fears, fear of crowded places, enclosed spaces, like a train, like a tunnel, and traveling away from home. Sitting in the middle of a row of seats, preference for aisle seats so that you can escape easily. Agoraphobia sufferers, or we call them agoraphobics, like to sit near the door so they can escape easily. Why? Because they're afraid of being trapped. They're fearful of the fear, and nobody is there to rescue them, to help them when they are experiencing fear. They fear strangers because they think strangers are less likely to render assistance when they need it. So they avoid situations where help is not available, and they try to travel with a companion. Social demographic characteristics of agoraphobics are that the lifetime prevalence is between 2 to 6%. In clinic studies, 3/4 already have developed agoraphobia with panic, and in community samples, half have agoraphobia without panic. The reason why there is an increase of 3/4 with already a panic with agoraphobia is because by the time they go to the clinic for help, they have already developed this secondary condition of panic disorder. So we looked at agoraphobia, which is a fear of the fear, and then we look at social phobia, which is a fear of social and performance situations in which embarrassment may occur. What are they fearful of? They're fearful of being judged negatively for a poor performance. Anything that they do which can be observed by other people is considered as a performance, and fear that people will judge them to be anxious, incompetent, stupid. And so social and performance situations are avoided. And what are these situations? Initiating and maintaining conversations. So they cannot make small talk, they can't introduce themselves, they can't take part in group activities. Dating is a no-no. Speaking to authority figures. The person who has social phobia will procrastinate talking to his boss or emailing his boss or anybody in authority. Attending parties or eating in front of people is avoided also. Speaking, writing, on the phone, writing in front of people are also avoided. In males, using the public toilets because they think that people are observing them. And when people are observing them, they take a longer time to pee, and then they worry what are people thinking about them. So the personality characteristics of social phobics are that they have low self-esteem. They tend to have low, poor social skills, and they're very sensitive, and they fear criticism. They're self-conscious and sensitive to perceived criticism. They tend to be self-critical and perfectionistic, and they believe that anxiety is visible, obvious to other people. And so when people observe them and think that people observe their anxiety features, they think that a person will think negatively of them. And social phobics are less likely to get married, more likely to be divorced, they have fewer friends, they have difficulty making friends, they have more trouble getting along. Very often they think they are negatively judged. They're more likely to be unemployed or underemployed. So these are some of the situations: dating, group discussion, talking to superiors, eating, speaking on the phone where other people can hear their conversation, attending social functions, birthdays, parties, weddings, or working being watched by others while you're working. In community studies, females outnumber males. So generally, results from community studies are more reliable. Clinic studies are more biased towards help seeking. So in community studies, females outnumber males. In clinic studies, male equal female ratio, 1:1. Marital status, they tend to be single, divorced, or separated. And in the US, a large community survey called the National Comorbidity Replication Survey, or the NCR survey, shows the lifetime prevalence is 12%. This is very, very high. In Europe, it's about 6%. In Singapore, it is so rare that we don't even bother to measure the prevalence rate of phobias in this country. In the US, it's the fourth most common condition behind depression, alcohol, and specific phobia. Now, with regard to educational level, the results are rather mixed. Some people say the better educated are more likely to report. Some others say that the lower educated are more likely to have this condition. Others found no correlation. Age of onset is 13 to 20, and they don't tend to seek help for up to 16 years, which is quite a long time to live with this condition. And there are two subtypes of social phobias: generalized type, in which they fear most situations, and a non-generalized type, which is more circumscribed, more confined to certain social situations only. Now, what is the difference between shyness and social phobia? Shyness is more common in 40% of the population. Social phobia is rare, but while shyness is more like a personality trait, social phobia is an illness associated with other comorbid conditions. For shyness, there's no socio-economic difference. You could be very rich and shy, you could be very poor and shy. For shyness, it's a transient situation because you can outgrow your shyness. Whereas for social phobia, if you're not treated, the condition tends to become chronic. For shyness, there's no social skills deficit, whereas for social phobia, there is definite deficit of social skills. So the difference between social phobia and agoraphobia: for social phobia, it's a performance anxiety, fear of embarrassment. For agoraphobia, it's fear of the fear of fainting and losing control, fear of the panic attack and nobody's to rescue, fear of social situations. For SP, avoidance of social situations. But for agoraphobia, there's no avoidance of social situations. In SP, there's no fear of enclosed spaces. In agoraphobia, there are fears of enclosed and open spaces because there's nobody around to render assistance. For SP, they do not need to bring any travel companion. For agoraphobias, they bring a travel companion along. SPs are fearful of familiar persons. AG, agoraphobics, are fearful of strangers. For SP, the age of onset is earlier. AG, age of onset is later. Social phobias, male-female ratio is 1:1. Agoraphobia, female outnumber males. For SP, it's more greater anxiety with familiar people because it is the familiar people that tend to know you more, that can spot your anxiety better than strangers. But for AG, they are less anxious when familiar people are around. So what are the causes of phobias? Genetic factors, increase in first-degree relatives. In twin studies, monozygotic twins have a higher chance of developing this condition compared to non-identical twins, because monozygotic or identical twins share the same genetic material. And then those who study brain activity found that certain parts of the brain, like prefrontal cortex, amygdala, hippocampus, are involved in anxiety. Many years ago, even before the Second World War, two researchers, Watson and Rayner, they did this experiment with a little boy. He's maybe less than 2 years of age. And actually, this is a very bad experiment because they tried to induce fear in the little boy. When they presented a white rat, the boy was very curious and showed no fear. But when the rat was presented to the boy and the researchers made a loud sound, the boy associated rat with something fearful and something noxious, so he developed fear of the rat. So what was initially a neutral stimulus has become conditioned to produce fear in this little boy. Now, Jones found that when a feared object was paired with a pleasant stimulus, so when you see a rat, you're fearful, but when you feed the person with ice cream or something that they like to eat, this reduced their fear. And this kind of pairing of two kinds of stimuli has been utilized in treating people with anxiety condition, and this is called systematic desensitization. Modeling of fearless behavior. Now, behavior can be learned. You can be afraid. You can learn to be fearful when you see people being afraid. Similarly, you can lose your fear when you see people not afraid and touching a rat, touching an animal, and you begin to lose your fear when you observe. It's called modeling of fearless behavior. Now, Maurer, professor of psychology at the University of Illinois, has found that fear can be learned through conditioning. We mentioned that little Albert was trained to become fearful of rats. Now, when the person runs away or avoids this stimulus, then this fear becomes reinforced. Instead of overcoming your fear of rats and mice and animals, you run away from it, your fear is not going to get better. In the long run, it's going to get worse because you've never discovered that there's nothing so dangerous about the animal. You've never learned to overcome your fear. So that's why we advocate exposure therapy, to expose people to whatever they are fearful of, to get them to see there's nothing so dangerous about that stimulus, that object. We mentioned there's chemical imbalance in the brain, serotonin, dopamine, and observing their mothers being fearful is another way of developing fear. And mothers or fathers are described as overprotective. Because you're overprotective, you don't allow your child to experience the stimuli around them, to explore the environment, to develop fearless behavior. Or some people also have developed social phobia because they were being ridiculed, being bullied during their school years, early years. Simple phobias is a collection of miscellaneous types of situations where people can be fearful, like heights, water, animals, insects, lightning. Okay, we've discussed generalized anxiety disorder, panic disorder, and phobias. And the phobias, there are three types: agoraphobia, social phobia, and simple phobias. Now let's talk about the management of anxiety disorders. Firstly, psychological therapy. The therapy which has gone through much study from randomized controlled trials is cognitive behavior therapy, which involves identification of negative thoughts and dysfunctional beliefs. For example, I'm useless, I'm going to make a fool of myself, and then challenging those negative thoughts and asking the patient, what is the evidence that people are going to laugh at you? You give a talk and people yawn. What's the evidence that they find your thought boring? And then encouraging them to find rational answers. Why are people yawning? Is it because the talk is boring? Or are there other reasons? So you encourage them to think of other reasons. So you're looking at the situation from various angles. One of the reasons could be they had a bad night, they had poor sleep the night before, they're very tired, they worked very hard, they didn't sleep enough, they're very tired, so they're yawning. Or they just had a heavy meal, they're yawning. So cognitive therapy useful for GAD, panic, depression, obsessive compulsive disorder, phobias, and post-traumatic stress disorder. Other psychological therapies could be dynamic, psychotherapy, supportive, interpersonal therapy, family therapy, group therapy. So I mentioned exposure to the feared object or stimulus until anxiety gradually reduces itself. So if you're afraid of an animal, I get you to stroke an animal, okay? Maybe a friendly dog who doesn't jump at you, who doesn't lick you, he just sits there quietly. And then you get him to stroke the animal, okay? Sit there with the animal, and then gradually the fear is going to subside. Now, there are certain situations in which you cannot expose a person, like lightning or water and that sort of thing. So you use imaginal exposure. You cannot produce lightning, right? And thunder, you can't. So you get the person to imagine, okay? You may even show them a video of lightning, show them a video of water, swimming pool, people playing there, having a good time, that sort of thing. Relaxation therapy, which consists of deep muscle relaxation, passive relaxation, imagination, and breathing techniques. All this is part of relaxation therapy. Can help the person to calm down, but when compared with exposure therapy and cognitive therapy, relaxation therapy is not so effective. So for behavior therapy, the exposure must be in real life. Okay, if you cannot produce in real life like lightning and thunder, then you can use imagination, but real life exposure is much more effective than imaginal exposure. So exposure must be graduated. So you have to construct a hierarchy of feared situations and expose the person to the least feared situation, and when they have mastered that situation, to progress up the ladder to the most feared of the situations. You don't expose the person to the most feared straight away. That's called flooding, and that is very traumatic to the patient, and they will definitely chicken out and not come back for treatment anymore. So we mentioned about cognitive restructuring, identification of irrational thoughts, challenging negative thoughts, discovering rational answers to these thoughts. Then we move on to drug treatment. And the first treatment of choice, the first line treatment, is a group of drugs called SSRIs, which stands for specific serotonin reuptake inhibitors. And these are all the examples of SSRIs. They are very safe. You can take as much as you like, but you do not take above what has been prescribed. Okay, the maximum is about 200 milligrams, 4 tablets of fluvoxamine, sertraline. But even if you decide to take an overdose, you will not die. It's very, very safe. It's not going to affect your heart. It's going to cause you to maybe have some tummy problems, nausea, vomiting, diarrhea, this sort of thing, headache, insomnia, sexual dysfunction, and so on. Then there are SNRIs, and there's also NASA, which is also very commonly used in our hospitals, mirtazapine. Tricyclic antidepressants are actually the first antidepressants to be discovered in the 1950s and 60s. In fact, imipramine is the first to be discovered, but they are out of fashion because they can cause dry mouth, nausea. They can cause dry mouth, constipation, not nausea. They can cause dry mouth and constipation and blurred vision. And then there are antipsychotics called quetiapine, not because you are psychotic, but these will sedate a person, cause anxiety to be brought under control, so that your antidepressants like SSRI and SNRI can work better to suppress the anxiety better by adding on antipsychotic. But the dosage is lower than that for a psychotic illness. And then there are famous benzodiazepines, which can cause addiction. A lot of patients are fearful that medications cause addiction. And of these classes of medicines, only the benzodiazepines have a potential for addiction, especially lorazepam and midazolam. Alprazolam has been studied extensively in connection with treatment of panic disorder. So for performance anxiety, for example, you're going to give a speech, you're appearing before an interview panel, you can take lorazepam and propranolol. Propranolol slows down the heart, reduces sweating and trembling. So propranolol deals with the peripheral signs and symptoms of anxiety. Lorazepam, which is a benzodiazepine, deals with the inner symptom of anxiety, the inner restlessness, the inner fear. So take it 1 hour beforehand. So what is the cause and prognosis? As mentioned earlier on, anxiety conditions tend to be chronic, they last many years. So people say, can I stop my medicine? Yeah, but then your illness lasts for many years. If you stop your medicine, your illness is still going to recur. Or when you stop your medicine, the symptoms become obvious again. So it's better to continue to take over the long term, okay? Until your stress is over, you've retired from work, you're no longer under stress, you can slowly reduce your medicine and see whether you have a recurrence of symptoms or not. So how can you help yourself? You can recognize the condition, you can seek professional help, manage your stress, remove yourself from the stressful environment, or if you can't, you have to learn to live with it. Practice relaxation exercises, breathing techniques, and muscle relaxation exercises. Learn to identify your negative thoughts, learn to refute your negative thoughts. You have to take care of your physical man. Sufficient sleep, rest, take a balanced diet, exercise. The American Heart Association recommends 150 minutes of aerobic exercise, 30 minutes a day, 150 minutes of exercise per week. And based on a 5-day week, this amounts to 30 minutes a day. In addition to the aerobic exercise, there also should be strengthening exercises, weight training, 2 or more days a week on all the major muscles, because when you train with weights, you develop stronger bones, stronger muscles and stronger bones, better posture. So these are examples of aerobic exercise. Aerobic exercise, when you work your heart and your breathing rate goes up, your heart rate goes up. These are kind of exercises that stimulate heart rate and breathing rate. Now, exercise and longevity. Some people have said, well, I take this vitamin, I can live longer, but this is not borne out by research. Research does show that exercise can increase your lifespan, longevity, okay, and decreases the risk of death. Healthy food pyramid, you're supposed to eat food at the bottom of the pyramid. Eat more food at the bottom of the pyramid compared to food at the top of the pyramid. Should I take vitamins? Well, you take vitamins not for long life, but take vitamins for nutritional problems, when you need to increase your energy, you're working very hard, you're very fatigued, then you can take the following vitamins. I found Q10, coenzyme Q10. Coenzyme Q10 is found in the cells, in the mitochondria of a person's cell. So this is a naturally occurring substance which is useful for energy production. Calcium, vitamin D, we work indoors, we roll down our sleeves, we don't have enough sun, and so we don't have enough vitamin D. So our bones become a bit osteoporotic, a bit brittle, and it can break easily. So exposure to the sun, if you don't want to expose to sun, take calcium and vitamin D. Vitamin D increases absorption of calcium. So vitamin C and E and omega fish oil improve your immune system. Now there's a lot of flu bug going around, right? So you want to take more vitamin C and fish oils. Activities for relaxation, choose any activity that suits you best, but be consistent. So all these are the various activities you may want to engage in. Time management is very important because we all only have 24 hours in a day and we can never grasp time. It slips through our fingers like water. Don't waste time, don't procrastinate, cut down preamble. Some people have to go and get a drink, go and stretch themselves before they settle down to work. So these are all the preamble you should cut down as much as possible. Start your work, fine-tune later, make a big start, okay? You don't have to fine-tune straight away. Make a start and then you can fine-tune the work later on. Beware of trying to do too much in too short a time and don't leave things to the last minute because you're going to give yourself more stress. So these are two books I've written about anxiety, Freedom from Fear. The other book is called Confronting Your Anxiety, a Biblical Response to Overcoming Fear and Worry. So in conclusion, medications to be used when symptoms are disabling and severe. Dosages should be carefully adjusted. Drugs are used to treat symptoms, but underlying stress factors should also be tackled. Non-drug therapies, counseling, psychotherapy should also be considered. And with that, I thank you for coming tonight.
Now, the exciting part. Oh man, the questions are coming in fast and furious. You don't need to ask questions, but you can actually vote for your most agreed questions and points. First one, Dr. Leslie, is it true that all prescribed medicine used to treat anxiety has side effects?
Usually, drug companies are obliged to publish a list of side effects, usually for medical legal reasons to protect themselves. It doesn't mean that any of these side effects will apply to you because you may take a medicine without any side effects. So we can't predict which patient is going to develop a side effect from taking the medicine. So for some side effects could be quite severe, for others there are no side effects at all. So it's very unpredictable. Okay.
Yeah. Okay. This one has got some votes as well. Someone who suffered from panic attack refuses to see doctor or go for counseling or talk about it. And this person is unemployed more than 30 years, no friends. How to help this person?
If they don't want help, how are you going to help them?
Yeah.
Yeah, you need professional help because 30 years. So you can ask the person, you can ask them a few questions because you no point telling them, no. You got to make use of your life and fulfill your greatest potential. No point, it's going to fall on deaf ears. So you can ask them some questions. What do you hope to do in the next 5 years, 10 years? No, the last 30 years not been working. So what do you hope to do in the future? Would you like to get better? There are a lot of people who have improved or got well, or maybe you have some common friends who have got this condition and they have improved and they're working or they are enjoying life. So would you like to be like them? So you can ask them a series of questions. I think that is a better approach to the problem, to the friend.
Yeah. Yeah, I mean, it's a predicament actually. To the person who's asked this question, the other way is the family and those concerned and affected like yourself can go and seek social help, social services at a nearby social service agency or even at the SSO, social services, social service office. Yeah. Okay, quick one. Is there a relation between anxiety and ADHD?
There are two separate conditions, right? So there is really no correlation. I mean, ADHD, you may develop anxiety as a result of maybe a school situation or work situation. There may be a secondary condition, but these are actually two separate conditions on their own. It doesn't
could
mean
be comorbid, right? It could be comorbid.
It could be, but not necessarily so.
Not necessary, yeah. Yeah. Okay. Next, can you share something else that's beneficial besides the conventional info that's widely available, like going for therapy, taking medicine, exercising more, etc.?
I'm a conventional person, no. I tell you something, not boasting. I'm an author of 2 clinical practice guidelines, 3 clinical practice guidelines. And I shared the working committee by the Ministry of Health, and we published it clinical practice guideline for anxiety disorder. And I'm also on the team, the work group for an international publication, clinical practice guidelines from the World Mental Health, World Biological Society. So what I've shared comes from these practical guidelines, these
Yeah.
expert guidelines. Okay.
Yeah.
So I don't have anything unconventional to share with you, unfortunately.
Yeah, and especially we're all bound by ethics and conduct. So
Yeah.
it's best that we avoid this. But of course, by all means, go research on alternative, therapies and all that. Yeah, maybe not here. How do I know if I have social anxiety, or is it just my introverted personality where I do not really like to mingle with people?
Yeah, that's a very good question. Social anxiety is a condition that develops from a period of normality. So when you're normal, you can interact with people, and then you develop this condition where you just shun social situations, and you get maybe you get anxiety symptoms, you blush, you tremble, you sweat when you have to face a situation where you have to speak or to work or to mingle with people. Okay, introverted personality is something which has been with you since you were born, and it manifests itself, say, in the late teens, really. Okay, but an introverted personality doesn't have to have social anxiety. See, so introverted personality starts earlier, social personality starts a bit later.
Mm. I guess another follow-up question to this, Dr. Leslie, is when do I know, or when do I know when I need to go and see, either psychiatrist or psychologist to check this?
When do I need help? You need help when it interferes with your daily life. A lot
Mm,
of persons are introverted, but it doesn't interfere with their daily life. They can still be very successful. In fact, a lot of CEOs have introverted personalities. They're quite shy. They don't mingle easily, and they don't need help, or they can have some coaching that help them to overcome their shyness. But social anxiety, definitely you need help, because you can't just overcome it just like that. By the snap of a finger, you can just snap out of it. You can't. You just need some therapy for that. So
yeah.
if it interferes in your daily life, yes, you need help.
Mm, yep. Next question. When someone who is easily triggered because of noise or arguments, this person will react by shouting, screaming, tremble, breathless. Is this considered panic attack? And then how to help or calm him down?
Usually, panic attacks are characterized by anxiety symptoms that arise out of the blue, nothing triggering them. So, if there's noise or arguments, it may or may not be a panic attack. See,
Mm,
panic attack, I mentioned there are 13 symptoms. You get at least 4 or more, then it's a panic attack, and you're fearful that it will come back. Usually, when there's such a type of trigger, may not be. Yeah? It may not be. It could be just a normal response to noise or arguments.
I
Right?
see. So am I right to say, Dr. Leslie, so panic attacks happen in the absence of a trigger
Yes,
more often than not?
arise out of the blue. A
Out
good
of the blue.
example is nocturnal panic when you're sleeping.
Ah,
You're in sleep, and then you suddenly awake with panic attack.
okay. Wow, something new for me. Okay, next question. Let's go down now. Someone who's in a job transition remains unemployable because of age and might suffer a disorder. What is the likelihood of an adjustment disorder, generalized anxiety, or panic attack?
In other words, how do you differentiate between adjustment disorder, GAD, or panic? Adjustment disorder is where there's a stressor, and then symptoms of mild anxiety, mild depression arise within 3 months of the stressor. There must be an identified source of stress. And when the stress has resolved, those symptoms should go away. That is adjustment disorder. GAD, we mentioned 3 big groups of symptoms: psychological symptoms, physical symptoms, and sleep problems. Panic attacks, we mentioned there are 13 symptoms. You get 4 or at least 4 out of the 13 symptoms, you call it a panic attack. And for panic attack, usually a person summons an ambulance and rushes to the A&E department because of catastrophic symptoms, fearing they may die or lose control of themselves, fearing that something terrible is happening to them. So when a patient has to rush to A&E department, you suspect it's a panic attack, especially if the doctors at A&E have done their tests and they've shown there's no abnormalities found in your heart and lungs. Then it's likely to be a panic attack.
Okay. And for those who are viewing and wondering about this question again, we can always send you the video replay, and please go through the content that Dr. Leslie has given. There's one here. I think I lost that, but never mind. What do you think of supplements like 5-HTP, alpha GPC, okay, L-theanine that boost serotonin?
Well, I'm not very sure of that. I'm not very sure that all these can really boost serotonin. Theoretically, 5-HT, you take 5-HTP, theoretically it can. But as a supplement to increase the level of serotonin, how effective it is, I don't really know unless we have a look at the studies, the outcome studies of these compounds, right? So I would say that I wish not to comment and make a firm, give a firm answer as to whether they are effective or not.
Yeah, okay. Yeah, so this is the one. This question, does one need to go for blood tests when taking mental illness medicine? When is it required to go for a blood test?
Okay, you need to go for a blood test to exclude thyroid problems, renal problems, certain glandular problems. So you need a blood test to exclude, but not when you're taking medication. When you're taking medications, there are only certain types of medicine, like lithium. When you take lithium, then you need to go for a blood test. Or you're taking antipsychotic medicine, you need to go and test your lipids, test for sugar and that sort of thing. So the other medicines like antidepressants, you don't need to go for a blood test.
Okay, thank you. We take a few more questions, okay? Must
Yeah,
one have all the symptoms to be diagnosed with a disorder?
no, not necessary.
Okay. And of course, please seek the professional opinion of a professional, psychiatrist, psychologist. Medicine is given by psychiatrists based on the description by the patient. Isn't that risky? As the person's brain is subjected to doctor's prescription, which might be wrong.
Now, for your information, in psychiatry, 80% of the diagnosis is based on history. So the more accurate your history is, that means you're telling us very truthfully what are your symptoms. 80% of the diagnosis arises from your symptoms. 20% is from the doctor examining you, talking to you, observing you, and listening to your speaking, observing you. So, unfortunately, there are no blood tests to diagnose any mental condition, no scans or x rays to confirm the diagnosis, unlike a medical condition like hypertension, diabetes, and so on. You can cancer, you can do a scan and then you can see the tumor. For psychiatric conditions, there is no blood test or investigation to confirm the diagnosis. 80% of it is from history, 20% is from the mental state examination.
But there are tools, right? So, like assessments and scales. Will there be?
We base scales, yes, for research, like to see the severity of the condition, or you want to use certain rating scales. Okay, that means you for the purpose of research, you say that you have this back depression inventory, or you have a Hamilton depression rating scale, that kind of thing. Yes, for the purpose of research, actually, to quantify the severity of the condition. Yes, yes. But for usual clinical practice, we don't make use of rating scales. We make use of taking a very good history.
Okay. Next question. Any scientific study or findings to conclude why women are more prone to anxieties than men?
Actually, the real reason is still not established. There are a lot of conjecture and a lot of hypotheses. Okay, a woman gives birth, and after birth, postnatally, they're more prone to anxiety and depression. And also before the woman goes into menopause, the pre-menopausal years is when there is a decline of hormones, which also can affect the mental health of a woman. Women are also more prone because of multiple roles at work, at home, caring for children. These kind of multiple roles puts them under greater stress. And I want to add just my own personal observation. Women are more meticulous than men. When you're more meticulous, you're more prone to feeling disappointed because your expectations are not met, and you find that things, you spot mistakes more. So you feel, and also women are more emotional. They're more expressive of their emotions. But that doesn't mean that men are not prone to anxiety, because alcohol rates are higher in men. And for depression, suicide is higher in men than women in a ratio of 1.6:1, or 3:1, or 2:1. So men also can suffer from anxiety and stress and depression. It's just that they don't express it so much.
Thank you for that. Last three questions. Is treating anxiety only possible in medicine? Any other ways?
Yeah, there are psychological treatments available. But for psychological treatments, you've got to be psychologically minded. You've got to be quite open with your thoughts and your feelings. You've got to be quite expressive, and you must be quite willing to accept advice. And maybe some therapists will give you homework, like to go and expose yourself to train stations, that kind of thing, you see. So there's homework to be done. So there's a lot of cooperation needed from the client as well, if you go for non-medication approaches.
Okay, this one is, I think, a repeated one, asked differently. If one has panic attacks due to certain triggers, like hearing or about situation, etc., that they are uncomfortable with, is that categorized as panic disorders? I think you answered that already, Dr. Leslie. Is it the same?
Slightly different.
Okay.
Due to triggers. Oh, due to trigger. Yes, panic attacks. I mentioned that usually they don't need a trigger, but they can also be triggered off. Yes. Yes. For example, if you were really traumatized by accident, right? You were accident victim. So you're hearing news of accidents, watching television programs, can also trigger off a panic attack. It's possible.
You mentioned the pairing, right, of a neutral situation.
Yes.
Last question. If a patient were to stop their prescribed medicine for anxieties, will it aggravate their medical condition?
Good question. If they were to stop their anxiety medicine, the anxiety may recur. And when a person's anxiety recurs, it may interfere with their medical condition. Yes, it may worsen their medical condition. That's possible because a lot of medical conditions worsen by stress and anxiety. So the answer is yes.
Yes. Okay, and that, well, probably one of the first times we answered everything and in no part due to Dr. Leslie's very brief but concise answer. So thank you so much again.